And so my name is Luigi, and I'm an associate professor in Bari University in Italy, and a researcher in Moru in Bangkok. These are the two houses where I've been in these years. So that's my hospital in Italy. You can see it's quite big and not functional because it was built by the fascist regime, and they like big things expanding. But you can imagine taking a patient for a CT from one side to the other. And that's Moru Mahidol Oxford Research Unit in Bangkok that has been supporting, together with Nix Moru, Shamira, Abi Rashan, the work of the registry. So, I was speaking in the afternoon. I don't have a big agenda, but I did come with 3 questions. So, why are we here? Why are we reflecting on ICU registries, ICU research and quality improvement? I would like to give a few examples also from international other registries of how we can use data to improve quality of care. What role did ICRU have, or can it have, in the wider CCAA, but also the LOGIC network, of which I will speak to you about, and then some concluding remarks based also on what I'm taking from this meeting today. So why are we here? I think all of us, independently from what we do, we might be nurses, data collectors, physicians, nurses in charge, but we do care about our patients. So this is a last patient I left yesterday. You can see very complicated, many ICU pumps and supports and dialysis, etc. And I learned this morning that the patient didn't make it, and I knew it was a very difficult situation. And the same happens in different settings. Dr. Ronnie in Mombasa has exactly the same patient level kind of doubts that I have. And what we want to do is, we do have our clinical practice day by day. Sometimes it's brutal. We want to translate it into data. That's why we are here a little bit. And then translate that data into quality of care, and maybe, as Arthur really nicely showed, transform that quality of care into regional or national policies. And we have to do this by collecting data, and I really agree that data is not anymore the bottleneck, but there are other bottlenecks. I mean, how does then these data help us change practice? So let's take an example of a thing that unfortunately we use every day, which is a car. I mean, do we really know the lights that we have up there? And if I ask you, do you know this indicator on your, how do you call this in English? Dashboard of the car. Well, I think, we all know this, right? Are the lights. But then if I ask you a yellow one, this is something to do with the engine. It might be, Club C rate. I don't know. But if I ask you about this one, you know what this is in your car? It's the handbrake. Yes, when you put on your handbrake. But if your handbrake is not on, and this goes on, then you are in a serious trouble, because it means there is a big problem in your braking system. Did you know this? So now you know. So with George Salu and some people, we actually wrote a paper a bit about this, saying, do we really know the dashboard of our ICU? Maybe we know the speed, the length of stay, mortality rate, but maybe we don't really use the standardized mortality rate. And the other indicators like Club C and IVAC, and someone this morning was speaking about VAP rates. And then what about our processes indicator? Or that's even more complicated. And our outcomes. And the structural, well, nicely that we spoke about structural indicators today. And then there is new indicators coming up. And Arthur nicely spoke about the economic performance that we now have to keep in mind. We spoke about ICO, etc. Workload. Workload is a hot topic now. Nurses and workload, but also physicians. So reality looks more like this, right? Clinical practice is complicated, and we're burned by it. Data, also, I see many data collectors in the room. You know, in the survey, thank you, Herbert, we saw I don't have issues with data, but I think we do have issues with data quality, and we have to be transparent about this. You know, it's not a round blue kind of circle. It's more complicated than that. And this matters because, yeah, Cornell already showed this when we collected this data a few years ago from many studies out there. You know, in our lower middle income countries, you know, mortality is quite high, but it's also high in other countries. If you get into the ICU in Italy, you have maybe 20, 30%. In Bangladesh, you go to 40. And we now know from Motivate and other papers that in Uganda, we are around 49% for ventilated patients. And as Cornell says, well, we cannot really change the GDP, but we can change some other things. But apart from the patient, I think we are also in this room today for another reason. I think we are here because we care about ourselves and about what purpose we have in our clinical lives. We are all physicians or nurses or data collectors. And I really like this editorial, which tells us, as a physician, what do? You apply knowledge. You know, your cognitive focus is about the patient, is about the illness. Your decision-making is rapid, and you respect authority. General, you have this risk management kind of approach to things as a clinician, and the basis for remuneration is efficiency, numbers, effectiveness. But if we are in this room, I think we want to be more. We want to be what this article, and I think the literature now is calling in the medical curriculum as well, we want to be physician scientists or nurse scientists or data collector scientists. And this is a bit different. We approach knowledge in a different way by discovery. We have a different cognitive focus. You know, the response to mistakes is not risk management anymore, but a mistake becomes an opportunity. And we do question authority, but we do also try to advocate. So I think this is important to remember. So these are the two reasons, patient and then our own purpose to be here. And putting these two things together, then this can really, as you're showing in this room, and as CCA has been showing, can build a pathway to successful scientific capacity in Uganda, in Africa, like this nice paper showed. Arthur really told us about number 7, but how do we get to number 7? We do get by building capacity, having high quality data, and the other things showed here. We recently mapped how many registries there are out there, and there are 35 countries with a registry, and Uganda is one of them. You can see in Africa, the white area that's showed by Cornell also applies to registries. So you must know that you are not alone. There is a lot of learning that can be taken from ICRU, and there is also a lot of learning that ICRU can take from some registries that are there for more than 30 years. But it's also important we reason a little bit on what are the questions that we are going to answer using our tool, because it's simply a tool, nothing more. And how are we then going to take this data into policy change? And we are lucky because if you have a doubt about what is a good question in your ICU, there was a recent exercise done by the network together with a very robust organization into prioritizing research questions in the ICU. Just look from what they started. They started from 432 different questions, and then they ran down and down and down until they prioritized 11 questions. And maybe they align with your interests, maybe not, but it's good to check. And look what is at number 1, number 2, the things that we have been discussing today, like socioeconomic impact of ICU care. But also then there is some clinical issues like infection control and patient triaging and antimicrobial stewardship that we've just heard today. So it's good to know these are the priorities. They might not align with yours, but it's good to know they're out there. So what are a few examples on how we can leverage registry data to improve care? If there was a fire in my house, This is the only registry paper I would save from my house. I really love it. It's what can we learn? And it was written by people who have reasoned on registry data for a long time. And the aim of measurement is really to provide quantitative indicators with the aim of improving one or more among structure, process, or outcomes. And lesson 1 in this paper is make the important measurable, not the measurable important. And I'll bring you just one example because Cornell is right, we don't have time. So some years ago, the Swedish, very high income country, very precise Swedish, they realized in their registries there was a problem with nighttime discharges and weekend discharges. And so they observed an association, there was a consistent finding with the literature, and they noticed that different ICUs were behaving in a different way in Sweden using their ICRU Swedish registry. And so they thought, hey, let's put up a national program that you find there to improve nighttime discharges and weekend discharges, because these people are dying more in Sweden. And they actually improved mortality. A few years later, Gartner and colleagues said, okay, if this applies to Sweden, then it must apply also to Australia. They did the exact same thing and nothing changed in Australia. So there are things that are context specific, and will focusing on nighttime discharges and weekend discharges change anything in Uganda and ICRU? You don't know until you really dive deep into it, but other experiences can help. So reporting of quality indicators, data quality is everything. And we really cannot speak enough about this. And some years ago, we analyzed the quality of the platform, and we were quite well established against all criteria that were internationally, explicit rule, collection of raw, the things that Herbert and Shamira run today. And now we're lucky to have an ISO kind of certification. But also, it's not only the quality of the platform, we need to look at the quality of the individual data. Lesson 3 from the Lytton paper is mortality benchmarking. This is necessary, but maybe not sufficient, and maybe it's not even important. In our registries, it has not been a central point. It is a central point in some registries. So the Italian registry, just to give you a perspective, is one of the oldest. So it's there from 35 years. Its name is GVT because in the name they put the group for the evaluation of intervention in the intensive care unit. They're really focused on that. And let's say you visit Italy, you go and visit the Colosseum in Rome. Let's say you have a heart attack, okay? And you end up in an ICU in Italy. I mean, will you know the quality of that ICU? You will not know. Because this graph here, which comes into the reports of Italian registry, is not publicly available. This is telling me that these are all the ICUs in the registry in Italy, and it's telling you that this is a forest plot. If you are an ICU on the right, then your mortality is superior to the expected, and if you are on the left side, then your mortality is inferior to the expected. And if you have a heart attack in Rome while visiting the Colosseum, where would you like to go? I'm sure you would like to go to the left, right? And the red one was my ICU, because this is how the benchmarking works. You know where you are, you don't know the names of the other ICUs. Otherwise, the benchmarking will never work, right? They decided to put this public, and they were very scared about what would happen if this goes public, but nothing happened. Like the Netherlands has this data public. People can see what is the mortality, length of stay, standardized mortality of places. So let's think also inside ICRU, do we want to benchmark? How should we do this, etc.? Because there are also many issues with standardized mortality rates that are well. And actually, when low and middle income researchers came together in a big Delphi indicator exercise published in intensive care medicine, you can see standardized mortality is not even there. They have chosen to put ICU crude mortality number 6 because there are many issues with standardized mortality, but you can also see what are the other 14 prioritized indicators in this list, and you can choose one to act, as Arthur said. It's too difficult to act on several. Choose one and go for it. And the Uganda registry, we recently mapped all registries in the world. The Uganda registry does have many of the indicators needed to go forward. So why we're here, we're also here to identify unwarranted practice variation, and this is really what we should focus on. Not the practice variation, but the one that cannot be explained by case mix or cannot be explained by other clinical reasons. It's called unwarranted practice variation, and it's there where you can really find a quality improvement initiative. Do people know how they perform? I really love this study from the Netherlands. They were trying to assess how people felt about their performance. Doesn't matter what, they were assessing on a dashboard looking at pain indicators, but it relates to many indicators. So look what happened when they asked people, you know, what is your perceived performance on those indicators on the y-axis, and what is the actual performance? So we usually try to overestimate our own practice. And that is also, I think, one of the reasons we are here, because if we are in this room, we are also aware and conscious that we should, you know, bring the reality to the table and try to improve. Number 3, registries can be a leeway for local action. You know, sometimes forget about the word registry. So this is an example from Swagata Tripathi in India. She was really interested by what happens to tracheostomized patients in her setting in India, which is quite difficult. And so she built a phone app and an entire intervention with videos to and many other things to care about these patients. So nothing to do with the registry, but she spotted a problem thanks to the registry. And then she created a quite complex intervention. Looks easy, but then when you read the paper, it's quite complex to solve that problem. So your local passion, be it antimicrobial stewardship, be it tracheostomized patient, really embrace it, defend it, because that's where then a national initiative will stem from. Another example is coming from India. So the registry can help us to identify context-specific patterns that are unique to your setting, Uganda or India, whatever. And this is quite complex. It's telling us about persisting critical illness. You know, how do the comorbidities, the green line, how do these explain patient outcome? In high-income setting, they explain it more and more as length of stay goes forward, while the admission SOFA or admission score usually don't explain after, but Bharat could not replicate the same in India. And so this goes back to what Cornell was saying, copy-pasting doesn't work. We really have to test theories. The theory can be developed somewhere else, but you have to test it in your own registry. And you can, of course, focus on context-specific populations, like we nicely heard from the residents. And I was happy to see, you know, pediatrics, sepsis, acute brain injury in the program, because this is one aim of registries internationally. And can you end up on intensive care medicine top journal with a registry paper? Yes, you can. This is the Australians, and they were simply describing what is happening with the acute hypoxemic respiratory failure. You cannot bring this word to the ministry, as Arthur said, but you can bring it into an ICM paper, because they show that while the burden of this stayed the same in Australia in 20 years, the mortality went down, and they showed this through the registry. So something good has been done with these patients. But what is the future bringing to us, to our registry data? So something that is popping up slowly from the ground and that you should be aware of is emulated trials. So the use of registry data to answer questions in a way that would be very similar to a clinical trial. So we know that we can embed clinical trials in the registry. We know this, and Uganda has been a champion in this. But we can also use data that is already there to perform an emulated trial and answer a research question that usually would only be answered by a clinical trial that costs millions and years, etc. So this is something that maybe you want to think about, maybe build expertise, statistical expertise, data sciences expertise for it. And last is what role for ICRU in the wider network. So I will not say what the network is, Adam already showed. I am bringing you this idea that is coming from a colleague just in the last few days, because we have now to think about what will happen after 1st of January 2027. We do have to look for our own funding. And Dr. Duncan from UK and Dr. Diptesh from Nepal, they are going to join forces and write an application for the NIHR in the UK concerning AMR and bacterial and fungal infections, especially regarding point-of-care diagnostics, PCT testings, and some localized prescribing guideline and antibiogram that we have already heard from Nakasero this morning, but they are going to try and make this an intervention to test in a clinical trial. So anyone in the group interested in such an idea, please do reach out to your national leads and to these people to write the application together. LOGIC, no time to describe too much, but is a network that I help a little bit to support joining all registries together, the ones that want to be joined into one network that is looking at benchmarking, international benchmarking, quality improvement, and clinical research. Uganda is there already from a few years. It's only using available data, a few publications out there, and some that are really telling an interesting story. This is not yet published, but look what happens. If you take all patients in your registry, ventilated and non-ventilated in all the countries of LOGIC, so going from high income to low income, and you put the countries, the GDP of the country, as the GDP increases, the mortality goes down, but you cannot really show a clear pattern, right? It's quite weak. If you only take ventilated patients, then look what happens. And here again, as Cornell showed with Motivate, intubating is quite easy, but maintaining and weaning and discharging an intubated patient quite hard. Skip this. There is some other LOGIC projects that are starting. This is again only using available data, no new collection. One in cancer patients from Brazil, one in pediatric intensive care registries, and one focusing on obstetric patients around the globe. So if you are interested in any of these, please do reach out. And one I'm really passionate about that we have started thinking about is climate change and what is it bringing to our ICU patients. So we know the temperatures are rising everywhere, but should my friend Dr. Mohammed in Bangladesh worry about this? Should Adam worry in Bali about rising temperatures? We really want to find this out at a global level in ICUs. In Uganda, despite your favorable position, you do also have a problem with rising temperatures. I really like this paper. It's only coming from a tiny hospital in Uganda, but they could demonstrate in Windy that there was an association between rising temperatures, hospital admissions, and increased mortality. But this is well shown. Hospital admissions is well shown around the globe. What is not well shown is what's happening in the ICU. And we have evidence that rising temperatures will bring complex pathology, multi-organ dysfunction, as you can see, basically in any organ. But while there is good evidence on some other things like mental health and climate change, cardiorespiratory disease worsening and climate change, we really don't know much about what will happen to critical illness and ICU admissions. And so this is the Extreme ICU project that we started. involving or trying to involve most registries around the globe. We have now piloted the model, but we are now working all the ethics. And this shows also an idea that you can run through LOGIC, because LOGIC is putting together many national registries like ICRU. So if you have an idea, then you can maybe secure some small funding, you can do a pilot of the analysis, then you go out to other registries like we are doing with Extreme ICU also in Uganda. And we also application for this project. We'll know about it in October. And this is where the ICRU came in. And let's see if this can help sustain also the registry research in the next 3 years. And this is how the ClimateCute grant looks. I don't have time to go through it, but we really want to study patients' trajectories entering the hospitals in different settings around the globe, see their physiology, see the in-hospital temperatures, how they vary, what's the impact on critical illness, and then we have an entire section countries. The data pipeline is robust. At the national level, you really have a data-centered culture that is quite unique. The private-public balance is the strength of your registry, and the early career members, as we could see today, it's such an advantage of this team. We have challenges. We do have to look at what will happen in 2027. We have to find funding. But we know this is the only way to answer this question. This is working because we are doing all these things correctly. So where are we going from here? We are already doing some things like registry-enabled observational research, motivate, ICRU, immunology papers, and other papers. We have been doing this already. Maybe we can work a bit more on clinical trial specific projects. Maybe no one will be interested in funding a network. No one will be interested in funding the ICRU network if you call it a registry network. But if you call it a network embedding a clinical trial, then they get more interested. So the synergies with the perioperative track, but also the participation in the call, NIHR call, or other project-specific fundings for 2027. Please think about it, because getting funding for clinical trials is nowadays, unfortunately, much easier than getting it for a registry. Emulated trials. Think as the world is moving towards this, already embed in your team capacity, maybe the next ICRU PhD candidate can be working on this. ICU performance and QI. We don't write implementation science grants. We should be doing that more, because implementation science is at the center of improving quality. There is a lot of evidence being generated out there that never gets translated. So it is true that it's harder to get a successful implementation science grant, but it's possible. And of course, participate with other registries in international calls like you've been doing with Prof and now with ClimateCute, hoping that this will go well. Thank you so much.